people are connecting to audio still, so I will wait until I know people can hear me. Good morning, happy Wednesday to everyone. Good morning, good evening, good night, wherever you are. Welcome to Wednesday Morning Report. Zavin and I are excited to hear a case from one of you guys, if you have one, and also discuss with two of you also. We are in the same room as usual. I'm so used to usually looking at one computer that I'm throwing myself off here, sitting right next to Zavin on a second computer, but I'm doing this because I wanted to just share some reflections on the case from, I think it was Saturday. So it was a case brought by Lena, the chief resident from Ascension Providence program in Michigan, that she shared to Robbie. That was just a really cool case. It was actually one of the first weekend sessions hosted by a residency program that I've been able to watch. So I just wanted to share kind of two nice kind of reflections or take home points for me from the case, which was the case of a 41-year-old gentleman coming in with kind of 1 month of fatigue, jaundice, and had abnormal liver function tests. We, basically heard over a week he had been developing a fever, feeling more sick, getting jaundice, getting more light colored stools, darker urine, and he came in from this. He had a relevant back history of having come originally from the continent of Africa. We didn't hear which country, but he had lived in Africa and also had a history of discoid lupus, for which he was chronically on hydroxychloroquine. The kind of two take-home points I want to bring is just sort of to take you up to the labs, which really helped fill in the story, which showed marked hepatocellular enzyme elevation with predominant AST, ALT elevations. Both were in the upper 600s, with relatively mild bilirubin elevation to 4 and alk phos to the 280s. Lina, the chief who presented the case, in sharing their diagnostic workup, actually just did a beautiful implicit teaching session on what to consider with extreme hepatocellular enzyme elevation, meaning what is the short list of conditions that can inflame and kill hepatocytes all at once. So she gave us a bunch of viral hepatitis serologies, hepatitis A, B, C, as well as herpes simplex virus, CMV, EBV. So viral hepatitis is on the list. She gave us Tylenol level and mentioned that ceruloplasmin testing was normal. That sort of hits the category of toxic injury, whether exogenous from medications like Tylenol or endogenous from excess copper. She gave us a normal right upper quadrant ultrasound with Doppler, which hit the ischemic category, whether from lack of arterial perfusion, which really just happens in shock, or venous fat congestion in Budd-Chiari. And then she gave us autoimmune serologies, an anti-smooth muscle, ANA, and this gentleman actually had a 1 to 80 ANA, as well as in his immunoglobulins, a high GGG, indicating autoimmune hepatitis is one of the other big ones. So in just giving this robust workup that her team did, which was fantastic, she really taught us implicitly viral hepatitis, autoimmune hepatitis, toxic injury, and ischemia are some of the biggest reasons to get your AST, LT towards the thousands. And then he got imaging for biliary obstruction also. Early biliary obstruction can do this as well before the liver injury pattern shifts to cholestatic. So it was really just that this wasn't an explicit teaching point in the discussion, but it was just beautiful to see how in the workup she really taught their approach to working up that problem. Ultimately, this patient got a biopsy. It really showed sort of a mixed inflammatory pattern that could fit with drug-induced liver injury versus autoimmune hepatitis. And I mentioned some of the serology suggested that, but with cessation of his hydroxychloroquine, everything got better. He was also put on steroids, and ultimately the diagnosis was thought to be drug-induced. The final teaching point Lina made with the case, and this is why I wanted to share my screen, is what a valuable resource the website LiverTox is. And if you're not familiar with this, this is a compendium of drugs with a national database here run by the NIH. Sorry, let me just scroll to the top of this, many known medications that have a liver toxicity. And it's just a fantastic resource to go to if you've got someone with liver injury you think could be drug induced. It's actually housed now on the NIH website, so it looks almost like a PubMed entry. But you can just see, it just gives this wonderful alphabetical record. And if we went to H for hydroxychloroquine and clicked on it, it's really nice because it gives you sort of the background and the risk of this medication for drug-induced liver injury, which again was thought to be the cause. And this gentleman with acute hepatitis and improved with steroids and cessation of the med. So it's just a really great case. There were many other beautiful discussion points as always, but Lina herself did some fantastic teaching that I just wanted to reiterate and share with you guys. All right, I'm going to slide over and be on Zavin's screen now. See you in 1 second. Hello.
All right, everybody. How we haven't had any action in the chat yet. Does anybody have a case? Thanks, Andrea. It is our primary goal.
Oh, Hans, I just saw your point in the chat. I'll just thank you for bringing up. There was a question of whether the hydroxychloroquine itself was causing a immune-induced autoimmune hepatitis, meaning it wasn't clear if the mechanism was directly drug injury on the liver or drug injury activating an immune response that was causing hepatitis. I thought that was a clinical entity I hadn't heard of before the case. Thank you for reminding us. But it really has some parallels in other drug instigated, but ultimately immune mediated condition like statin autoimmune myositis, right? Where exposure to the statin, even when the statin goes away, makes an ongoing autoimmune inflammatory process. You know, in this case, with cessation of the drug, everything got better. Granted, she was also on immunosuppression. So in the end, it wasn't clear, but that was just a cool kind of middle ground entity is drug inducing autoimmune inflammation, which we've seen with other organ systems before. Thanks for bringing that up.
In the case of the liver, that's thought to happen with nitrofurantoin too.
Yes. Oh, okay. Yeah.
Sort of. So yeah, there's liver specific examples too. Who wants to discuss? Okay, let me make this like a little bit easier. Oh, okay, Rafael, great. If Rafael has a case, then we just need a couple of discussants with us, please. And yeah, always fun, no pressure. First timers and returning discussants, always welcome. And CP Solvers team members also always welcome. I was going to offer to present an old case too that I don't think you've heard before. That was really cool.
Next time.
Next time.
It's hard for you to have a case I haven't heard because that's what we do. We share interesting cases with each other most of the time. Yeah. It's unrecorded RLR, except it's ZLS. Just doesn't quite have the same palindromic power as RLL. Right. Anyone? Should we could do a Stefan Zavin show if you guys insist. That's another possibility. But we'll wait another minute to see who else would like to jump in. Brody, have you gotten a chance to say hi to the group on prior morning reports already?
Yes, I think I have already introduced myself.
Great. Okay.
Okay, well, just in the interest of time, we can say going once. Staring at the chat, hoping something will appear. going twice. All right. Maybe Steph and I can just discuss ourselves. We'll keep each other company, I guess.
Okay.
Not be too lonely. So Rafael, let's hear the case. And if somebody wants to jump in halfway, by the way, maybe we can do it that way, where we'll just kind of look at the chat more, interact with the chat, and if anybody wants to kind of unmute spur of the moment and share ideas, please do so.
Okay, so I'm gonna give you the chief complaint. The chief complaint is severe diffuse abdominal pain associated with diffuse maculopapular rash.
Okay, let's talk about that first.
You want to kick things off?
Sure. Severe diffuse abdominal pain and rash. Okay, so just some sort of thinking out loud first about abdominal pain. Most people think of the quadrant approach, and that can be helpful anatomically to think about what's in one quadrant versus the other. And certainly if there is a clear quadrant localization to the abdominal pain, that can be helpful. If someone says it hurts down here in the right lower quadrant, left upper quadrant, you can think about sort of what's there that could hurt, and the localization could be okay and helpful. However, if the pain is midline or diffuse, the problem is not necessarily in the midline, and it's not necessarily diffuse. So for example, if I have an occluded cystic duct, that's actually going to hurt in the middle, even though the problem is on the right side. If I have an obstructed appendix, it's going to hurt periumbilically, even though the problem is, on one side. And then with diffuse generalized abdominal pain, again, you don't know what the original source is, and nor do you know, you could have diffuse peritonitis, right? Or you could have small bowel obstruction with some abdominal distension or bowel distension, and again, because of the mapping of the pain intervention in response to distension or ischemia, the pain can be very vaguely localized, diffuse, generalized in the midline, etc. So when you have diffuse abdominal pain, in my mind, the problem could still be distension or ischemia of a hollow viscus. It could be global peritonitis, or it could be in the sort of category of like non-anatomic causes of abdominal pain, right? Some of the sort of metabolic syndromes or metabolic diseases that often present with abdominal pain. Things like hypercalcemia, things like ketoacidosis, things like porphyria or adrenal insufficiency, etc. And then let me just take a step back. When I say diffuse peritonitis, the other possibility is, potentially a sort of an initially focal problem, like like pancreatitis, for example, right? Or like a urinary tract infection that is sort of really severe and is involving bilateral sort of upper urinary tracts or whatever, where it's not, you don't necessarily think of as the peritoneum as the problem, but again, whatever inflammatory process hurts so much that pressing anywhere on the abdomen is painful. Okay, so
Want me to hop
you
on?
want to
with the
help with
rash?
the rash, and then we can see where there's overlap?
Yeah. I think hearing about this rash whose distribution we don't have yet, that'll be an important thing to factor in. But I think really hearing about someone coming in with a rash, the question first in my mind is, okay, based on whatever else is going on or not going on, am I worried about a skin limited process or something systemic? And in this case, we know this person's got a bad abdominal pain. So really, we're going to be looking for overlap of these categories, as Zavin said. But I would put sort of a maculopapular rash in the sort of non-specific inflammatory symptoms of the body that we often put things like fatigue and fever, meaning there's a whole host of categories that it can go with in those sort of inflammatory syndromes we talk about a lot. Certainly infection, there's a great overlap between abdominal pain, excuse me, of rash and infection. Rash and malignancy, yes. Now there's different neoplastic rashes that happen in the setting of malignancy, and certainly cancers themselves can infiltrate and look like a macular papular rash. Leukemia cutis comes to mind as a common one for that. Autoimmune conditions, absolutely. We've seen a lot of cases on Virtual Morning Report where systemic inflammatory disease is manifesting in the skin also. And then we were just talking about drug-induced pathology with the reflection on the prior case. So I really think infection, malignancy, autoimmune, and drug are really all on the table when you hear maculopapular rash, often with another kind of organ system in well at the same time. So what can we put on the list with the abdominal pain and the rash? I know what we can take off, right? Right now, I think some of the very specific abdominal pain syndromes because of organ injury and inflammation don't fit with rash, like a lot of the itises, appendicitis, cholecystitis, pancreatitis. We don't really associate those with maculopapular rashes. So I think some of the more organ specific pathologies might actually fall lower in the list compared to more whole system inflammation that's causing more diffuse abdominal discomfort for the reasons you said.
Yeah, and I think diving into your categories with the rash can help to find overlap. So within infections, what infections can cause abdominal pain and rash? With the rash, I think mostly of viral, right? Like viral exanthems that oftentimes can also involve the GI tract and cause pain. We see a lot of typhus here in Houston, and it's amazing how non-specific and kind of multifaceted and multi-organ the involvement is. I've seen chief complaints, certainly of headache and rash and fever, but also of like pulmonary symptoms, people just presenting in like AFib with RVR. Abdominal pain is often a feature. Other bacterial infections.
Kushal's got a great thought of typhoid, absolutely, right? That would be sort of classic with the abdominal rash with typhoid discomfort.
Perfect. So we thought about viruses, some bacteria in particular, specifically like some of these like more atypical bacteria, right? And then within mycobacteria, fungi, parasites. Parasites, yes. So, a lot of parasitic infections like strongyloides and schistosomiasis, obviously, the chronic carriage is in the GI tract. And sometimes it can manifest with abdominal symptoms, more diarrhea rather than like acute severe pain, but sometimes the kind of obstructive complications can happen. But it's not at all uncommon to have intermittent sort of systemic parasitosis and these transient sort of urticarial rashes with these chronic infections. So potentially there. Malignancy, again, not as prominent probably, some of the autoimmune diseases this doesn't sound like a vasculitic rash. So similarly, Still's disease involves a lot of serositis, right? It often has pericarditis and pleuritis with it. The peritoneum is another serosal surface that is often involved by such processes. So potentially you could have that happen. But I'm seeing in the chat that probably the most epidemiologically likely overlap of this presentation of severe diffuse abdominal pain and a cutaneous eruption, especially if the onset is acute, and that is an allergic reaction either to medications or substances. So on the sort of anaphylactoid spectrum, right? And anaphylaxis or mast cell mediated havoc in general involves four main organ systems: your vasculature, vasodilation, hypotension; your bronchi, spasm, shortness of breath, wheezing; and then the effects of histamine on the gut, which can be crampy abdominal pain, diarrhea, vomiting, and then mucocutaneous involvement. So either maculopapular rash like this, more angioedema of the mucous membranes that you don't see I think that's probably the most likely overlap in this case.
Let's hear some more, Rafael.
Okay, awesome discussion, by the way. It's incredible how much you guys can delve into the discussion with only the chief complaint. So we have a 20-year-old girl that presented to the ER with severe diffuse abdominal pain for 1 day. This patient also developed a diffuse maculopapular rash, including both hands and feet, that was itchy. This patient 3 days ago, she developed headache, a high fever of 39.5 Celsius, myalgia, diffuse arthralgia, and nausea. This patient also has non-bloody, non-bilious persistent vomiting, non-bloody diarrhea 3-4 times a day, and dizziness. And she took diaperon for the headache, but it didn't help. I'm gonna give you also the background of this patient. So past medical history, she had a previous episode of diffuse maculopapular rash and fever 3 years ago, but she didn't seek medical attention because it self-resolved in 3 days. This patient has no surgical history, no medications, family history. Her father has hypertension and mother has diabetes, no cancer history, and social history. She was born and raised in Brazil with no recent travel history. And that's the end of the aliquot.
Interesting. So we see with the additional information that we have that, as we suspected, this really sounds multi-system sort of inflammatory, right? With the fever, with the headache, muscle aches, joint aches. And the acuity of the onset is really important, right? We've often prioritized infectious etiologies when someone comes in with 1 day of something. But in her case, this episode is acute onset, but it's really interesting to hear that perhaps somewhat of a similar syndrome that self-resolved happened years before. I'm not sure what to make of that right now, but it just makes me want to sort of think beyond once we develop an initial infectious differential diagnosis of what could be going on with this. So I think tackling infection first, just with the time course of this episode, makes a lot of sense. Maybe we can tag team sort of our categories again. I think back to viral, we don't hear much about, or we don't hear about any upper respiratory symptoms, but I did think of measles initially, just with the extensive rash, the whole body involvement, just something to think about and consider if there's been an outbreak in her area and what her immunization status is. You want to do a bit of a back and forth there?
The palms and soles stand out, right? We typically think of Coxsackie virus as involving the palms and soles, and certainly could account for a syndrome like this. Oftentimes with Coxsackie virus, interestingly, I have a lot more experience with Coxsackie virus as just like a random dude than as a doctor.
You mean someone who knows people who have children?
Well, yeah, basically, right? Like I'm not a pediatrician, so I don't see, but I haven't had a lot of patients with Coxsackie virus, but we know so many people, both kids and their parents, who've gotten Coxsackie virus. In fact, like of all our friends around our age who have kids who are like a little bit older than us, like more than half of them have had like either their kids and then they've gotten some of them have gotten it from their kids, and like so Coxsackie virus could do this absolutely. In fact, you wanted to show Julia's picture or no?
If I can find it, I can look in a second.
I think I might have it. Our niece here, yeah. This is one of our 2 nieces. Like right now, like 2 days ago. She has hand, foot, and mouth syndrome. Anyway, very common thing, could very much account for all of these symptoms. The happening 3 years ago, a little bit more weird, right?
I think we're working on the viral category. We've got I would put sort of enteroviruses in general on that. And then there's some great thoughts, which I totally want to support in the chat, of just mosquito-borne, right? Depending what area of Brazil this person's from, I think a lot of this could go, particularly that if the joint pain is severe with mosquito-borne illnesses, right? Zika, chikungunya,
Dengue.
dengue, absolutely fit in the viral category.
Can we ask? I don't know this. I don't know if Steph you do, but if somebody knows in the chat, or if you can Google it, of how often there's involvement of the palms and soles. I don't necessarily think of it, but okay. Moving on from viruses. Could this be syphilis? Secondary syphilis?
Why not?
The palms and soles are what kind of tipped me off. Syphilis is something that people get more than once. The self-limited nature the last time isn't as good of a fit. And then the way that the rash is at least described on the palms and soles, syphilitic rash, sure, absolutely. But like maculopapular, if it's like, people use maculopapular and morbilliform sometimes interchangeably, but let's kind of like delve into what that means. Maculopapular just means some of them are spots and some of them are bumps, right? And generally that they're small spots and bumps. If they were big, a bigger spot is a patch and a bigger bump is a plaque, right? So when you say maculopapular, you're generally referring to like smaller lesions. But morbilliform actually means measles-like, right? And that is in my mind, it's sort of like a subtype of a maculopapular rash where there's sort of certainly an erythematous component, at least that could be appreciated in lighter skin-toned individuals. And the bumps and spots are very small, so they don't approach anywhere the cutoffs of half a centimeter or 1 centimeter that you would sort of think more as like diffuse or confluent or patchy kind of rashes. And then the morbilliform, that type of rash is certainly characteristic of a lot of other viral exanthins, those other things that we have vaccinations against, right? Things like rubeola and rubella and fifth disease and all of those sort of like childhood febrile rashy common illnesses. But also drug rashes are, at least immediate drug rashes are often look that way. So I think syphilis maybe, but getting some atypical features of that.
Rickettsia still on the table, absolutely. All the various types that we've talked about, I wondered also because of the sort of buzzword of the rash in the palms about disseminated gonococcal disease as well. The GI symptoms don't fit my illness script as well, but certainly with sort of acute illness, something to sort of think about. We'll hear more on the joint exam.
And another type of infection that you can easily get more than once, so
yeah.
It kind of fits with the prior history.
But mycobacterial, fungal, parasitic, again, with the 1-day onset and the extent, just seem less likely. So maybe we can finish with non-infectious related possible triggers at this point in the context of this happening a few years ago.
Yeah. I don't know. I'm a little bit no clear sort of illness script is popping up as a good match for that. A lot of immune mediated disorders, whether that's rheumatoid arthritis or lupus or vasculitis, or they're often characterized by self exacerbations and remissions, right? So just the fact that it didn't progress and stay forever doesn't mean it's not an autoimmune disease. On the other hand, the acuity here described both this time and last time is a little bit sharp for that, to have like a very explosive onset and then all gone by 3 days. To me seems a little less likely to be a sort of autoimmune or autoinflammatory process. I think back to the parasitic, well, actually with one exception, why did what's the time course of Lofgren's and sort of limited sarcoidosis?
Pretty quick.
Yeah, pretty quick, right?
Very cute.
Fever, joint pains, especially in the knees and ankles, and hilar adenopathy. That's the Lofgren syndrome. Is that right?
Well, it's usually EN though.
And erythema nodosum, right? Not this type of rash. Okay.
we get more?
Yeah, let's get more information. Rafa, have we gone anywhere close to the diagnosis yet? Or are we
Don't
like,
tell us. It doesn't
okay,
matter.
don't tell us,
It's the journey, Gavin.
all right, let's
Yeah, it's the journey. Fun fact, I've had
Yes.
this.
look at us floundering right now. We really need our learners. We're
We're
not
so
used to
used
doing
to
this
depending
alone.
on you guys to carry us here. This is good for us.
Yes.
Just a fun fact, I actually had this diagnosis before. Okay, so when it comes to the virus, temperature is 39.5, heart rate 89, blood pressure 100/80, respiratory rate 26, and she's saturating 97% on the room air. When it comes to the physical exam itself, generally this patient is distressed with a decreased state of awareness. HEENT exam shows a diffuse headache with retroorbital pain with no lymphadenopathy. Her cardiovascular exam, this patient is tachycardic, no murmurs. Pulmonary exam shows right lung with decreased breath sounds, donors to percussion on the base, with decreased tactile fremitus and delayed expansion. Abdomen exam, this patient has diffuse tenderness on palpation. Neuro exam, just like I told before, this patient is lethargic. And when it comes to extremities skin, there is a non-palpable, blanchable, diffuse maculopapular rash on the face, hands, feet, legs, arms, and chest. And this patient also has cold extremities. And that's the end of the physical exam.
I'm worried about this patient. They look sick for a 20-something-year-old, previously healthy person to have altered sort of level of consciousness and encephalopathy like this. They're either very systemically ill or the brain itself is involved, which does happen with some of the viruses that we've mentioned are in the differential. They can also cause a degree of meningoencephalitis, and with some of the intracellular organisms as well. There's thought to be potentially some direct sort of effect on the brains, potentially via sort of a vasculitic mechanism like you often have with Rocky Mountain spotted fever. But regardless, this patient is sick, and if there is an intervention to be done, for example, doxycycline to be administered, it needs to be sort of potentially done on the earlier side if possible. We were going to talk about more about Neisseria.
Oh yeah, what's sort of layered on with the history here, besides the encephalopathy, whether it's encephalitis or not, is the just severe headache, right? And so that just brings to the top a lot of the viral diseases that also have tropism for the brain. And we talked earlier about just disseminated Neisseria disease in the form of gonococcal, but certainly meningococcal disease could present with sort of a diffuse rash also in someone this sick too, right? Sleepy, febrile. The pain, just kind of the pain particularly predominant behind the eyes, is just something to think about. I've heard that brought up with dengue fever before in particular. So I think just assessing for that and getting a sense of kind of possible exposures there. But the pleural effusion, I wasn't expecting either. I think the physical exam gives us a lot more about the systems involved in this now that we know perhaps CNS as well as kind of the periphery of the lung as well.
Yeah, there's some things that are, I think, just don't fit well, like stand out as like, well, what's up with that? Yeah, on exam, what it sounds like is a degree of pleural effusion, dullness, decreased fremitus, delayed expansion. I mean, I think it's possible that these could just be atelectatic kind of findings too. Certainly we need lung imaging but what even that we've named would cause a pleural effusion big enough to be picked up on an exam? I mean, it's one thing to have a little bit of like diffuse systemic inflammation and capillary leak and have like bilateral small pleural effusions, right? But to have a more kind of localizing asymmetric pleural effusion, have we named anything that fits with that?
No, I think a lot of stuff we've named make people generally leaky and third spacey, but you're right, this has to be fairly large to be able to be assessed on physical exam alone.
I am, you know, the rash, the fact that it's blanchable, right? I just want to point out that that's actually really helpful for a couple of things on our differential. So one, you know, vasculitic rashes associated with small vessel vasculitis, you know, think of them essentially as like the small capillaries in the skin are inflamed and thus fragile, and thus they rupture and you get tiny little microbleeds in the skin. So the rash, first of all, isn't this diffuse. And second of all, it's not blanchable. There's actually like blood that has leaked out of the vessels under the skin. So you can, if you put a clear glass slide on the skin and push, you'll still see those little red spots. Okay. Similarly, in disseminated meningococcemia and gonococcemia, what you can get is also a petechial rash that has a mechanism of coagulopathy, essentially of DIC, that similar to vasculitic rashes often at times is more on the lower extremities, dependent parts of the legs, but that too is sort of, it's hemorrhagic, right? So it wouldn't be blanchable, and it wouldn't be this diffuse. So this pattern of rash to me is a lot more like basically like immunologically mediated. Something in the skin diffusely is reacting to a stimulus and is much more typical of either viral or bacterial or sort of allergic-y type processes. So I think for me, I have kind of prioritized those in my mind. And by the way, someone I think mentioned in the chat, really good to notice absolutely that there's a very high temperature, but an unexpectedly slow heart rate. So that too can occur with some viral infections, but also atypical bacterial infections like tularemia, like brucella, like typhoid fever, like listeriosis, etc. And what do we want next? Certainly basic labs, chest imaging.
Yeah, and I think the one other thing I'll just mention, you know, the other thing that made me worry about this person, besides the sleepiness, the high fever, is despite the high fever, the limbs are cool, and that pulse pressure is a little narrow, 100 over 80. So,
oh my God, yeah.
Besides the temperature and the heart rate not going together, the body temperature and just the extremity of the limbs, and you know, we've named a lot of conditions that should make someone we've talked about vasodilation and third spacing. So why aren't the limbs really warm, and why isn't the diastolic blood pressure quite low? That also stands out to me as very, very worrisome. It just makes me wonder about cardiac function in general, but also that whatever is inflaming the pleural space, inflaming the pericardial space.
Oh my God.
We may not have information about sort of what the neck veins look like in terms of jugular venous elevation, but that is another piece of this in terms of just perfusion and pump function that worries me a lot about this person.
Super good catch.
Let's hear some labs. I think I'll just say we've talked about a lot of these kind of both viral and both tick-borne and other bacterial illnesses where I'm expecting certain labs to be abnormal. We'll see if it's right, but I wouldn't be surprised if the platelets are a little low, if the AST, ALT are a little high. I just put that out there because there's with this total body inflammation and acute illness, very, very often manifest in cell lines and or labs for other organs. But let's actually hear what they are from you, Rafa.
Okay, so the hemoglobin is 17.7. The hematocrit is 56.9. The white blood count is 5,150 with typical lymphocytes 53%. The platelets are 36,000 and sodium 123, potassium 3.9, AST 54, ALT 43, albumin 3, creatinine 0.5. And we also did some imaging that showed US ultrasound abdomen showed hepatomegaly with ascites, and the chest X-ray right pleural effusion. And there is one more aliquot which will reveal the diagnosis, which is a test.
So we've got a normal white count, but a high percentage of atypical lymphocytes. Higher than expected hemoglobin, I'll say, for a young woman who's, probably having some menstrual blood losses, thrombocytopenia as we predicted, mild AST, ALT elevation as we predicted, and mild hyponatremia. To me, sort of the atypical lymphocytes are perhaps maybe one of the lab results that can help point us in more of a particular direction. And certainly what comes to mind is some of the multi-system viral syndromes, some which we haven't mentioned explicitly right now, but any certainly mononucleosis like syndrome, which would include Epstein-Barr, cytomegalovirus, acute HIV syndrome are certainly on the table with that as well. And again, this is an acute presentation. We've talked a lot about infection, but certainly I think luckily the cell counts right now don't support acute leukemia, but I just want to say retrospectively, that's a whole category of acute illness I really wasn't thinking about given the young age, but anyone in sort of a blast crisis actually could have presented with a secondary infection looking this sick and unwell. Wasn't on the list, and then retrospectively, I think I would have put it on there, although I think the labs don't fit that right now.
Actually, I will say though that word of caution, whereas the current white count of 5,000, 50% atypical lymphocytes, they don't fit the pattern of acute leukemia with blast crisis that can present with a explosive multi-system severe acute illness like this. However, a lot of times automated CBC machines will read CLL cells, hairy cell leukemia cells, plasmacytoid sort of abnormal kind of essentially white blood cell cancer cells as atypical lymphocytes. So, but most of those are more like more chronic kind of rare leukemias or lymphomas that circulate peripherally. So anytime you do see that and you don't have a clear viral infectious syndrome, don't let it go and make sure that a smear has been looked at, by yourself or a hematologist or something.
Just one thing to point it out, it's typical lymphocytes.
Oh, typical.
Sorry. Okay.
Oh, sorry.
Thank you.
We heard atypical. Okay. That's still lymphocytosis though, right?
Yeah.
So that is still lymphocytosis.
So we've got very acute onset febrile multisystem syndrome with signs of third spacing and thus hemoconcentration. I think that's the interpretation there, with mild thrombocytopenia, AST, ALT elevation. So I think I'll just say this, to me, this brings us back into our acute viral illness category above all. I think some of the signs that have been sort of discussed before really make kind of dengue fever likely high on the list, and certainly a severe form of it. But are there other things that we should really think about up front?
I don't think I've been talked out of worrying about rickettsial illness or typhoid either. And I think I would give this patient both ceftriaxone and doxycycline while we're figuring things out, especially just given their acuity of illness. By the way, one more just comment, the hyponatremia, and while we're testing all these things with blood cultures and the serologic tests for both these sort of arboviral viruses, for herpes family viruses like EBV and CMV, HIV, as well as the other ones we mentioned. But no, I was going to say the hyponatremia, it's actually pretty significant. It's interesting. The hyponatremia is both non-discriminating diagnostically, because she's really sick, and sick people make ADH and they don't eat hamburgers. So I don't think it necessarily moves the needle in terms of like what's causing her to be sick, but 123 in a 20-something-year-old is low. There's not a lot of space in the skull that 20-year-olds have to swell into. And that hyponatremia may actually be part of what's causing her to be sleepy, causing her to have a headache, causing her to be vomiting. So, so I wouldn't let that get any lower, right? I would, obviously she's going to get some fluid. She's clearly hemoconcentrated, and hopefully she'll hold on to that salt, and the sodium would go up. But basically, if it moves in the wrong direction, I would potentially be a little bit more aggressive in treating it as potentially symptomatic hypernatremia and just trying to get that number up a little bit in the short term, lest she sees. Okay, Rafa, teach us stuff.
Okay, so this patient, we actually performed a serology. It was NS1 positive for dengue, IgM negative for dengue, and IgG positive for dengue. This patient was diagnosed with dengue and received volume expansion, which helped to improve her condition. Her hematocrit and platelet levels became normal after 4 days of hospitalization, and she was discharged back home. So just a little bit of teaching points. I think this is something that we don't think often, but actually when you have dengue for the first time, it's usually mild, but on the second time, it can be very severe because there is something called antibody-dependent enhancement that occurs when antibodies from the primary infection cannot neutralize the virus, and instead they help the virus infect the cells more efficiently. And the outcome is an increase in the overall replication of the virus and a higher risk of severe dengue.
Wow. Thank you. I just did not know about that sort of paradoxical worsening, right? I mean, it just seems counterintuitive, right? You have antibodies, you do better the second time, but wow, how really, really interesting.
Yeah, wasn't that something that came up with COVID, that there was some subset of patients who experienced more severe illness on the second go, and it was thought to be through the same mechanism. But yeah, I had no idea it happens with flaviviruses like dengue. How did the
patient, yes, the patient did okay. So that's why sometimes I'm like, oh my God, please God, don't make me get dengue again.
Oh yeah, yeah. And I'm seeing this great stuff in the chat, including Kushal's list of criteria for severe dengue, which this person really met well. I guess I'm curious, Rafa, the cooler extremities and then more narrow pulse pressure. Was there any thought on what was driving that?
So on dengue, there can be this what we call dengue with warning signs and dengue without warning signs, right? So when we have severe dengue, there's this massive release of pro-inflammatory cytokines that leads to increased capillary permeability, like you guys told, like there's intravascular fluid in this interstitium leading to hypovolemia and hemoconcentration. But this can progress to circulatory shock and multiple organ failure, and also thrombocytopenia, including leukopenia, because you guys are like, why there is no leukocytosis? Because it is actually expected in dengue leukopenia and elevated transaminases. And even other things like meningoencephalitis, myocarditis, hepatitis, which can occur at any time during the course of the disease.
Wow, fantastic. Thank you for the great teaching and the great case.
Thanks so much, Rafael. Andrea, do you want to summarize the teaching points for us? And we'll just review some of the lessons and scroll through the chat a little bit more.
Sure. We started with a patient with abdominal pain. Sometimes we think on the quadrants make us think on anatomy, whereas when the pain is diffuse, it can be a projection of the pain and you really don't know the origin. This can be caused by pancreatitis, UTI, global peritonitis, and non-anatomical causes like metabolic disorders. Then we started with a patient that had rash that could be something in the skin versus something systemic. And we have maculopapular rash that refers to some small spots and some small bumps that tends to be not specific, can be caused by infection, cancer, leukemia, cutis, drug-induced pathology, measles, or mosquito-borne illnesses. And specifically, morbilliform refers to erythematosus measles-like subtype of this rash. And another thing that we should have into account is that vasculitic rashes, those are microbleeds, they are diffuse and non-blanchable. We have a patient, our patient had rash and abdominal pain, so we talk about typhoid fever, systemic parasitosis, allergic reactions, rickettsia or something autoimmune. Because the patient had his pulse and soul compromised, we talk about Coxsackie virus. And because the patient had something, an episode similar and she recovered, we talk about syphilis because you can get it more than once. And the first time can be is self-limited. Then we mentioned the Lofgren syndrome, that is an acute form of sarcoidosis characterized by erythema nodosum, bilateral hilar lymphadenopathy, and polyarthralgia or polyarthritis. Then severe headaches, the severe headache that the patient had made us think about disseminated Neisseria, meningococcal, or dengue. And the fact that the pleural effusion was picked in the physical exam gave us an idea of how severe it was. Then we talk about the Paget sign, that is a sign in which the patient has fever and bradycardia, can be caused by typhoid fever, tularemia, yellow fever, and Legionella. And this is an interesting fact for the hematology lovers, that CLL, hairy cells, and plasmatoid cells can be read as a typical lymphocyte, so it's important to have a smear. We talk about, and Rafa told us about this interesting phenomenon that is antibody-dependent enhancement of dengue infection, in which the body immune response makes the clinical symptoms of dengue worse. Thank you very much.
Thank you, Andrea. That was awesome.
Great case, Rafa. I really enjoyed it. Wonderful to see you guys all here on Wednesday.
Yeah. I was just, I don't know if anybody else found like the question about the palms and soles. From what I could tell online, it does happen in dengue. It's just not very common. Typically, you have the morbilliform rash sort of diffusely. Palms and so the hands and feet are sometimes swollen, but to have the rash there is reported, but not like super typical. So really interesting to kind of refine the illness script with that. Yeah.
Great.
Thanks, everybody. You have a great day.
Rafael, I just wanted to clarify, was the IgG positive or was the IgG, because I kind of...
No, I can send you. Just one final thought. I think it's super important, because sometimes when you see these patients with arthralgia and we want to give NSAIDs, you know, for example, any non-inflammatory drugs, right? Like to improve the condition of the joint pain. You can't do that with dengue. If you're suspecting dengue, there is this inhibition, platelet inhibition by these drugs, and it can lead to like severe bleeding in those patients. So if you're suspecting dengue, please don't do that to your patients.
Great point, Rafa.
Thank you. Y'all are awesome. Hope you have a great day.
Bye, everyone.